Welcome. Here's our agenda for our Project Echo Dementia session. See some familiar names. I see some new names, and welcome to all of you. We'll do some opening notes and reminders. We'll do some introductions, maybe via the chat. If it's your first time with us, if you would be so kind as to put in your name, where you are joining us from, clinic-wise, maybe a specialty, that'd be great, just so we know who's here. Then we have the great good fortune of Dr. Barak Gaster, one of our hub team members, talking about cognition in primary care. FORC, primary care by primary care, and then a revisitation of a case from Julie Holgado from one that she presented last September. So full agenda. And I'm going to move through this quickly in the name of time, but if you could put your names in the chat, especially if there's anybody else that's joining you in your setting, that'd be great. We're all masters of muting the microphone, but please do say your name when you unmute. That'd be great. And if you have the possibility to turn your video on, that would also be appreciated. There are a few other echo sessions that may be of interest. We'll send these out as resources, so we don't have to spend too much time on these, but some other things going on that may be relevant to your practice. We also would encourage and remind you to do everything we can to not share any PHI. We record these and have them posted freely available on our website, including patients and families who apparently access these on occasion. And then, of course, you will get a 1-minute post-session survey, just as we attempt to continue to refine this to make it the most helpful and beneficial for our community of learners. We are scheduled all the way through early June for our upcoming didactics and are busy formulating what the rest of the calendar year looks like. Would love your input. That's something else to think about for the survey, or if you have ideas and want to put things in the chat, that's great. There's also this upcoming CME for primary care from our partners at Swedish, and another lovely session from one of our collaborators and partners down at UCSF, Howie Rosen, differentiating behavioral variant FTD, AD, and other related disorders. And I think Allison's going to throw the link for that into the chat. Cases, we love them. You've got them. We'd love you to present them. And thank you. We've got, I think, 22 or so surveys from the end of the year. And really, these are so critical, not just in terms of being able to provide CME, but also to make sure that we are using your feedback to make this a better program. We are accredited for CME. We don't have any disclosures. And this is us. This is you. And this is Dr. Gaster, who will talk about cognition in primary care, and I'll let you take it away.
Great. Thank you so much giving me a chance to tell you about the work that I've been doing along with a couple of people from the Cognition in Primary Care program, who I see are with us. That is Dr. Jackie Rates, as well as Christina Park. And so thank you for running the slides for me. And so, yeah, it is really my pleasure to tell you all about the work that I've been doing along with this incredible team that you see here. This is the Cognition in Primary Care program, which is really all about concise, practical, better care within the primary care setting for people who have cognitive impairment. And I'm going to, just in the interest of time, sort of just give a quick shout out to Jackie Rates and to Christina Park, who are the two people on the team. So Jackie Rates is really my sort of partner in all of this in a really sort of meaningful way. She's a family medicine doc at Harborview, and is also a palliative care physician and does a lot of work in geriatrics and in the family medicine residency program. And her and I have really been sort of the main drivers in building the content of the training that I'm going to tell you about. And then Christina Park is really an amazing PhD student who's really been helping us to analyze the data that we have been gathering. So without further ado, let me tell you about the Cognition in Primary Care program. So go to the next slide. And so just to kind of frame it as to kind of what this is all about, just the incredibly common situation, as you all know, an 82-year-old woman who comes in to her primary care provider for an annual wellness visit and mentions, or maybe just marks on her annual wellness visit questionnaire that she's been worried about her memory. And I can tell you, just for years, I struggled with, my goodness, what do I do when somebody says this to me? I mean, and it's so kind of shocking that that is not sort of like an immediate, like, oh, I know what to do in that situation. It's like almost as if you walk into your primary care provider's office and say, I'm short of breath, and the primary care provider doesn't know what to do. But this is really like such a conundrum. Next slide. Just what do you do? Like, you may be very tempted to just say, oh my goodness, me too. I'm worried about my own memory, but don't worry, it's normal with aging. It's nothing to worry about. So sort of tempting, and I do think that this happens an awful lot in the world, to sort of dismiss a concern like this. You also might be really tempted to just like automatically try to get that person in to see a neurologist, and poor neurologists are sort of so overwhelmed with referrals of people who have like barely been worked up at all. I mean, it would be like as if every person who came in with shortness of breath, you immediately just like, oh, I've got a pulmonologist for you to go see, here's their number. That's just not necessarily good care. You could try to stop right then and there and do a cognitive assessment in the midst of your sort of crazy busy schedule, and then end up being 40 minutes late the whole rest of your day. Or really the focus of the cognition and primary care program is how to do a follow-up cognitive evaluation visit. And really the big light bulb for primary care is have a family member come to that visit with them. One of the most amazing things about primary care is how it is often this very one-on-one personal connection that you have with somebody over time. You don't necessarily bring a family member with you to your primary care provider's annual wellness visit, but you cannot do a good job of fully evaluating somebody's cognition unless they have an observer there who can tell you how that person is doing. And so a follow-up visit for a cognitive evaluation with a family member coming also is the way to go. Next slide. And really just making the case of just like how much this is a primary care disease, that we're on the front lines. Patients hopefully sort of have really sort of gained sort of trust in us, and we've gotten to know them over time. That long-term relationship is just so key for helping to work through and navigate what can often be a really psychologically difficult new diagnosis to make. We all know that specialists are incredibly valuable and important, but are sometimes hard to access. And also sometimes patients don't want to go see the specialist. They really want, they may be having trouble completely sort of accepting the fact that they have a problem, and that it is often the primary care setting in which that at least initial sort of evaluation management is going to happen. And so really the goal of the cognition primary care program is to really create a structured evaluation model for cognition to improve care and help us all. Next slide. And so really, and I think the big hook is just how getting over that kind of nihilistic feeling of like, oh, there's nothing we can do. So like, what is the value of opening up this big sort of psychological can of worms, and really making the case that better communication, better support, more family involvement that can come from an earlier diagnosis of cognitive impairment does improve care. It makes our lives easier. It makes the patient's care less chaotic. It improves the family's ability to support the patient. Absolutely just sort of solidly better care. And really the other big hook that we stress so much in this training is how much of a difference we can make in improving brain health now, that by treating comorbidities like sleep apnea and hearing loss, by evaluating possible medication changes to make, that we really can improve people's brain health now, and that it's not that it doesn't do any good to identify this disease early, because we can make a difference. Next slide. And so, it's all about just creating a smooth process for this evaluation. This is a screenshot of the website of the Cognition and Primary Care Program. This is where people can sign up for our training, and I'm going to talk about that in a little bit. There are summary clinical tools that are essentially handouts that are summaries of the training that we do. We link to community resources that are selected to be especially good for primary care providers to offer to patients. Next slide. And so this is sort of what we have accomplished over the past year and a half. And, this all kind of was initially thought up and before the pandemic, and we were imagining that we were going to need to sort of do in-person training. And I guess we managed to roll this out and get it all up and going through the pandemic, with the big silver lining, though, that we were able to pivot to doing the training via Zoom, which has actually been incredibly logistically wonderful. And it's really, so starting in 2021, the fall of 2021, we started offering this 3-part continuing education. We reached 68 primary care providers across the UW primary care network of clinics, and it's a network of 15 clinics across the region. And then in November and April, we piloted going out to 2 of those clinics to really give them a very, very concrete workflow to put the training into practice. Next slide. And the CME has been really, really well received. I think it's, I want to give a lot of credit to my colleague, Jackie Rates, who's with us here, just in terms of making this really, really high quality education that's really by primary care and for primary care. I think the biggest sort of framing benefit is just how much both Jackie Rates and I understand what it is like to be a primary care provider. And so giving this training about what is mild cognitive impairment, what is dementia, really from a primary care perspective, really resonates with primary care providers, because they understand that we understand what their world is like. And so, just really, really positive responses. And we even surveyed people 6 months after the training, and 91% still reported increased confidence in assessing cognitive concerns as a result of the training. Next slide. And, people, there's always the free text part of the evaluations, and people really have, really meaningful, nice things to say about it. And so that has really made a big difference in making us feel like we're on the right track. Next slide. And so here's a overview of what this 3-part series looks like. It's 3 parts. It's offered as live Zoom training. The first part is make a diagnosis of cognitive impairment. The second part is set a plan for a newly diagnosed patient. And the third part is manage dementia. And, really with the big sort of meaningful approach that just training primary care to evaluate cognition and make an earlier identification of cognitive impairment without also giving them sort of confidence and tools to manage it better is a little bit of a disservice. Like we're all about moving away from any kind of like a diagnose and adios situation where, it's like, oh, I'm sorry to give you this, like, potentially, serious diagnosis. But I myself am not really sure sort of what to do next. So I'm just going to sort of send you to a specialist without really feeling confident that I could sort of manage this if I needed to, and I probably will need to some extent. And so here's how to do it. So I think really we feel confident that by giving primary care more of a sense of like, yes, I can manage this disease, I really do feel more sort of engaged and open to identifying it. Next slide. Oh, and actually stay right there for one more second. Go back one second. because I'm going to put in the first of a few plugs, but the first plug is that we are going to be offering this training again starting next month in March of 2023. And so this is just the first teaser plug for that. It's free registration, and I'll give you more information about doing that. But before we move away from this, I want to let you all know that you all could register to take this training yourself if you'd like, starting next month. And that the registration is open right now. Next slide. And so here are the 4 steps that are really what we frame the evaluating and early detection of cognitive impairment. That starting out with being aware that the most common situation where this is going to come up is at an annual wellness visit, because there's some Medicare requirement to ask people if they have concerns about their memory, if not actually doing some kind of a mini cognitive assessment for everyone. But this will often come up, and as Jackie Rates has been like really sort of wise in bringing up, that this could be something that your front desk staff notices, or that your medical assistant notices, that somebody who used to be right on the ball is sort of starting to slip and not miss appointments, or not show up, or show up at the front desk at a time when they don't have an appointment. Like any of those sort of triggers should really sort of like raise our concern to think about, gee, does this person need a cognitive evaluation in the primary care setting? So that next step is really that decision point. So this concern has come up, and it may be possible to easily reassure some people who are, gee, I just find I'm misplacing my keys more, or it's taking me longer to come up with somebody's name. Those can be sort of very normal changes with aging, that not every person who has a concern like that necessarily needs a full cognitive evaluation. And so part of the training is giving primary care a sense of, gee, what are these big red flag warning signs that actually the type of concerns that should absolutely you need a cognitive evaluation. I really want you to schedule a long appointment coming up for a follow-up visit. Bring a family member with you. We're going to do a cognitive evaluation, and here's how to do it. And then really also making that 4th part being, if you do identify cognitive impairment at that evaluation visit, really how to structure that return visit after that, to discuss what the diagnosis means, and really set an initial plan for how to maintain somebody's health and support them as well. Next slide. And so here's a little bit more about what that decision point is about. It really is about, can you possibly really easily reassure somebody? And we give people sort of like 3 big sort of questions to ask that are taken from the 10 warning signs of dementia, that try to cover the 3 main domains of cognitive impairment. So not just short-term memory loss, but also executive functioning, sort of organizing complex tasks, or becoming disoriented in a place that they should know well. Like those are all really high risk concerns that absolutely somebody needs to have a full cognitive evaluation, that you're going to schedule as a follow-up visit with a family member present. And that really, we can now much more feasibly do that in the primary care setting scheduled as a longer appointment slot that can now be billed as a level 5 visit, which is twice as many RVUs as a level 3 visit, much more than it used to be a couple of years ago, really making this much more sort of complicated visit sort of financially feasible and sustainable in our busy practices. Next slide. And so here's a 3-part of what that evaluation visit looks like. It's a cognitive checklist, reversible causes, other factors that we can fix, assessing cognitive function using a MoCA test, and then getting input from a family member, which can be as simple as asking them 3 questions, or if we also provide a much more sort of detailed, validated instrument that's called the AD8. Next slide. And here's just a snapshot of what the first 3 questions of that AD8 look like. And this is really designed and validated as a brief informant interview of an observer to detect dementia. You can use it for the patient themselves as well, if a family member hasn't, or close friend hasn't come with them. And so it can be used in that way as well, but really the ideal way to use get information gathering like this is that you don't want just the snapshot of how somebody's cognition is doing in your office at that moment, which is what a MoCA test would be, but you really need to get some sort of external sense about how that person is navigating through their lives. And you can put that information together with the MoCA test to really sort of do the comprehensive cognitive evaluation in the primary care setting. Next slide. And so here is a snapshot of what the checklist that we've developed that is embedded in the UW Medicine version of EPIC that we are really sort of eager and happy to share with other systems. I mean, this is a very easy to import smart phrase that anybody's EPIC system can easily sort of incorporate. We have actually now it is now available on the National EPIC Community Library, so anybody can easily find this this smart set and download it into their own version of EPIC. But it's just very simple and concise. It's the type of things that you are all kind of well aware of what should a primary care provider sort of ask as part of an evaluation of cognition visit. You know, looking at their medications, really being careful to make that you know how much alcohol somebody is drinking. Is it possible that they could be depressed? Is it possible that they have untreated sleep apnea? Would wearing a hearing aid seem to improve their cognition? And making sure that the red flag question about visual hallucinations is asked at that visit, because if somebody has visual hallucinations, it really does raise a concern that they could have Lewy body dementia, which is a much more sort of less common than Alzheimer's disease and has important management implications. It can be a difficult, complicated distinction to make. But so I think that the main point being that in our training and in our checklist, we're making sure that we're asking if somebody is having visual hallucinations, and the answer is yes, and they are having cognitive impairment, that's somebody who really needs to see a memory specialist soon to help with that diagnostic evaluation. Next slide. And so we've been we've rolled this out about 1.5 years ago, and so we're starting to collect data among the UW primary care network physicians that we've been presenting it to, and we have definitely been able to show an increase in the number of MoCA tests that people are entering into the EPIC MoCA flow sheet. Next slide. And the second session, the second part of the training is, so now that you have potentially identified somebody who has either mild cognitive impairment or dementia, sort of what do you do next? And you don't try to stop everything and have the big giant counseling about that new diagnosis at that evaluation visit, but you really do want to have sort of an easy pivot for yourself to say, you know, gee, this is a lot to take in. I really want to make sure that we have a lot of time to review what these test results mean and make a plan for next steps. So I'm going to schedule you for a follow-up visit to have that discussion, which includes really difficult conversation, tips about how to talk to deliver serious news to patient and family, guidance on when to refer to a specialist, especially to get to a specialist quickly, and then what are key education and support resources to provide. And again, really giving primary care solid interventions that they can make to maintain somebody's brain health if they have cognitive impairment. Next slide. And we're also now in part of the training, and also what we're going to be putting into the UW Medicine version of EPIC is a checklist of what to do at that follow-up visit, where you're again going to it's really similar to the things that you wanted to make sure that you are assessing at the cognitive evaluation visit. But now that you are more concerned and more sure that somebody does have cognitive impairment, these are the things that somebody can do to really sort of maintain their brain health, that really sort of go hand in hand with all of the other sort of preventive things that we do in primary care, like how to keep people healthy. And then really that connection to community resources is so important. And on our website, cognitionprimarycare.org, is a list of the high value resources that we have collected that primary care can refer to. Next slide. And so again, this is our website. It's cognitionprimarycare.org. It's where you can access the handouts, the summaries of the parts of the training, access office workflow materials, get links to the high quality regional support resources. And that's where you can sign up to take our CME training, that training registration tab right there. The registration is free and open now for the sessions that we're going to be doing in March. Next slide. And so sign up now. These are the 4 dates that we have coming up. Again, this is all via Zoom. These are 45-minute sessions which includes time for question and answer. And I think that it's free. You can get continuing education credit for a very small fee through the UW continuing education office, but registration and taking the training is free. And just the slight caveat to still give is that we are still somewhat focused on the UW Medicine primary care audience for this curriculum. And so there are some parts of the training that are still somewhat specific to the UW Medicine version of EPIC. And so I just want to kind of warn you that if you are signing up and taking this training and you are not part of the UW Medicine EPIC system, that there will be a couple of slides in the training that will not necessarily be immediately applicable to you, because we do train, we're really trying to train the UW primary care audience to access the tools that we have embedded into the UW Medicine EPIC system. But that said, I think the vast majority of the content is not specific to UW Medicine at all, but just so that you're aware going in that there is still that focus on the UW Medicine audience for this training. But we do have plans to create versions of it that are less laser focused on the UW Medicine audience, mainly in terms of those EPIC tools. But I do think that this would be, really valuable and appropriate information for anyone, even those who are not using the UW Medicine version of EPIC. And so if you go to the website, cognitionprimarycare.org right now, you can sign up for these trainings. I think that Allison put this link into the chat, but really you can even just Google Cognition Primary Care University of Washington, and it should come up on Google pretty easily, or just typing in that URL cognition-primarycare.org, or click on the link that Allison put into the chat. Next slide. And we've got big exciting plans. This has gotten a lot of attention. We have really been able to engage with the CDC, who funded the initial sort of launch of this program, and they have been really sort of pleased with the progress that we've made. And so they just gave us a 2-year follow-up contract extension to expand the use of our model. And then we have also gotten funding from the Davos Alzheimer's Collaborative, which which is very, very keen on healthcare preparedness, sort of just engaging primary care to evaluate and identify cognitive impairment earlier. And really, like, our future plans are super oriented towards sharing this with health systems beyond UW Medicine. So for sure in across Washington State, but even nationally, the tools that we're developing are really, really simple. Like, anybody can easily import them into their version of Epic, or really even other electronic health systems other than Epic. The checklist is really, really simple, and there's nothing fancy about it. And really the model of the 4 steps of being aware and deciding and evaluating and then counseling, that model is workable within an existing primary care setting. Doesn't require like hiring a whole bunch of new people and setting up a new care line or service line. This is really designed for other health systems, other primary care clinics to easily just work into what they're already doing. Next slide. All right, so sign up for our CME if you're interested. Just remember the caveat that there's going to be 2 or 3 slides in the presentation that are mostly geared towards the UW Medicine audience. But the registration for is free. Taking the training is free, and you can also get continuing education credits for a $25 fee through the UW Continuing Education Office at the completion of the 3 parts of the training. And so I want to thank you all for having me and listening to me tell you about this work, and happy to answer questions. And I think that, Jackie Rates is still with us in case she wants to help answer questions as well. And thank you all for listening. And yeah, it's let's see, it's 12:49, and so I do need to run off to be with medical students in just a few minutes, but I'm happy to take 5 minutes of questions or so.
Hi, Brock. This is Jeff in Yakima, an outstanding program. There was a lecture this morning at Grand Rounds at Virginia Mason on memory impairment, and the speaker was recommending using a calculator for anticholinergic burden to better predict. And I'm wondering how you feel about adding something. I guess you type in the names of the drugs and it gives you a relative index that you can sum to see whether it would be significant.
Sounds great. Yeah, who was it giving the presentation?
I can't remember who gave the Grand Rounds. I got on a couple of minutes late, so I don't remember. I can look it up for you.
Yeah, that's a great suggestion. That's awesome.
I don't think providers always appreciate that. Even we think of something, like a Benadryl, something very sedating, but there's so many medications like antihypertensive that have just a little bit of anticholinergic burden. And you have someone on 20 medications, and it can definitely be impairing, even if they're not at anything that's obviously sedating. So it's definitely something part of our teaching, but a calculator like that can be helpful for people to think about that.
Yeah, I mean, for sure, like diphenhydramine Benadryl is the big sort of like sleeper demon. Like, I can't tell you how many elderly people take Tylenol PM because it helps me to get to sleep, and their doctors don't even know it. And so really making sure that you're asking about those medications is a really big part of our training program.
Other questions for Dr. Gaster or Dr. Rates? I have a quick one. Have you gotten any feedback about, boy, we tried to do this or tried to implement it, and here are the barriers we run up against? Or it seems so easily implementable, but there's got to be some hiccups.
Yes, for sure. I mean, this is, and we definitely, I mean, I think part of what makes Jackie and I's presentation so good is that we are absolutely, we couch all this as like, this is not the magic wand that's going to make all this like easy and simple. And there's going to be lots and lots of situations that are really, really sort of hard and tricky, despite, it's hard and tricky for anybody. The person who has like, terrible insight into their impairment, or somebody who, is this even really cognitive impairment or not, or is it something else that's going on? Just so common and hard. And so, yeah, so I mean, the big sort of like logistical barriers that come up are, do I have access in my schedule to do a long slot follow-up appointment right away? Not always, and that's just sort of baked into the difficulties of primary care.
Beginning, when Dr. Gaster presented the case of the woman who came in and said she was worried about her memory. And I feel like for most people, that's a very, very brave thing to admit, for a couple reasons. One is the shame and the stigma of, getting older and being seen as frail and feeble, not in control of yourself. And then also the other thing of, if I admit this, am I going to lose my independence? And as you probably know, people really do not want to lose their ability to drive. And so just that even first admission, there's something wrong. So
yeah.
I've heard from other people and seen myself sort of the, yeah, me too, or that's normal for your age, and kind of blowing it off. And I'd say if somebody actually had enough bravery to admit that, I think it may sound soft, but it could be a real cry for help. So to always take that seriously.
Yeah.
Well, I want to be respectful of your time and the needs of your students, but any other last minute questions? We will also look forward to hearing maybe an update as this progresses along and you collect a little bit more data. So always welcome to come back and give us a part 2.
Great. So thank you again for having me, and just a huge shout out to Jackie Rates, who has been absolutely instrumental in getting this off the ground and making it as good as it has been.
All right.
All right. Thank you.
Thank you. Excellent presentation. All right. So with that, we will now shift to our case. And thank you again to Julie Holgado for presenting this case the first time back in September and coming back around with some updated information. We've imported things into the slides. I'm happy to kind of drive for you, but let me know if you want me to move forward, backward, or what you want me to do.
Okay, sounds good. All right. Well, I'm Julie Holgado, and I'm a geriatric nurse practitioner through Cadlick Senior Health Clinic in Richland, Washington. And this is a 75-year-old female who presented last year to establish care at Senior Clinic, a referral from internal medicine for concern of dementia. Long-standing major depressive disorder for 40 years. Otherwise fairly healthy, independent. Her previous care was that she had a long-standing relationship with a neurologist who diagnosed her maybe 10 years ago with mild cognitive impairment, and then established with a different neurologist in 2020 who also tested her and said mild cognitive impairment, also had been under care of psychiatry. So let me follow the slide a little bit. So demographics, 75-year-old female, college graduate, had been a homemaker, raised 2 children, and volunteered, which was a big part of her life until 2020, which her volunteer work stopped with the coronavirus outbreak. And then she had stopped driving prior to that because of accidents. And history of falls, thankfully, none in the last few years. So her past medical, past surgical and social history, no history of tobacco, alcohol, or drug use. And her sleep, she's never had a complaint of difficulty falling asleep or staying asleep. She is actually, if anything, sleeps too much during the daytime too. We can go to the next slide. Her current medications are a little different than when she first established with me. She has been on multiple medications for a while. So she has been on Lamictal for probably the last 20 years for her depression, which so she's been on Lamictal, Wellbutrin, and citalopram for depression. She had been on Rexulti, atypical antipsychotic, when she first established, which then insurance didn't cover. So we switched to Abilify to try to get an equivalent. And then I started her on mirtazapine, and she had been on lorazepam for a long period of time as well, which we have been trying to taper down from. She was taking 3 times a day with an additional half tablet as needed. And she's attempted to decrease it based on her cognitive concerns. She's already decreased it to twice a day. And Trileptal, she's been on Trileptal for a long period of time as well for, I assume, depression. And then for her other medical concerns, so basically all her medications are for depression and anxiety, except for propranolol, which she's taken for essential tremor. Had been taking propranolol twice a day for essential tremor, and then lowered it to once a day based on her side effects with twice a day. We can go to the next slide. So her previous memory testing, her worst score was actually in 2018 with the neurologist, which had a Washington cognitive evaluation of 88/100. And then in 2022, when she established with me, she scored 20 out of her 30 on her MoCA. And then I just saw her again this week and retested her MoCA. It'll be on the next slide, with a score on retest of 26/30. And this is kind of her previous MoCA and her current MoCA in comparison. Now, in the meantime, between these two, I had started her on Aricept when she established with me at the senior clinic. Her executive function has always been intact. Her fluency on the MoCA, her fluency on we do pronounce it WACE test was poor, but her fluency on these MoCAs was normal. And so attention has always been her intention, and orientation has been the problem previously. Move on. Oh, so what's interesting is I made a little photocopy of a previous chart note, because I would say that this October 2020 clip is from her mental health provider's note. It says that her depression has decreased, but she's struggling with depressive symptoms, unmotivated at times, and is lying in her bed too much. That is pretty much the thing she tells me every time. In her previous internal medicine provider's note, he says kind of the same thing, that she has the same concern every time that she lies in bed, is demotivated, can't get up, having more trouble functionally, was what she started talking to her mental health provider about in 2020, that she can no longer cook as she has been, and she feels that she's having problems with her activities. And so when she presented to me in 2022, she was having more and more distress about managing finances. Her computer, she wanted to do things on the computer, but she was having more trouble using the computer, no longer keeping up with the housework like she wanted to. So this, and then in the December of 2020 is another clip from her mental health provider, that she's sleeping more, and still just the lack of motivation, depression, hopelessness, crying a lot. So we can go on. So these, I believe we can skip to the next, which would show the scores. We do have some scores from previous, this is the score from this week's appointment compared to previous. So it looked encouraging when I saw her in October, that mirtazapine was going to be working well, that her depression, at least staying on her previous medications, with maybe adding mirtazapine, might be helpful, because in October she was feeling pretty optimistic, and this follow-up she scored pretty low or pretty high on her anxiety and depression, and self-report was that this was affecting her daily life pretty much every day of the week. She is not getting out of bed like she would like to. She's not doing the things that she'd like to, and having frequent anxiety. She's telling me that she's trying to cut down on the lorazepam, so she only takes it when she's, very anxious or almost kind of panicking. And so I do believe that anxiety is worse with decreasing lorazepam. So I feel very poorly for her. I think on the next slide, we'll see the PHQ screening. We can go to next slide. And the next slide. So our plan, she had previously had some comprehensive lab work done and imaging previously done. She's due for yearly lab work with this last visit, and no plans for further imaging unless there's any advice on that. So next slide. So treatment, I told her this week that I'm very concerned with her mental health. She had lost her psychiatric provider at the same time as establishing with me from her mental health provider moving to private practice and not taking her with her to the private practice. So I have previously placed referrals for psychiatric care, and when I look back through the referral notes, it appears that the referrals were authorized but were not carried out because the patient would be contacted and would not answer the phone or did not schedule. So it appears that this last appointment, she is more motivated because of the worsening of her depression to seek psychiatric specialty care. And I explained to her that with her current medications, I don't think that the addition of further medication would be helpful, that actually with the right specialty insight, maybe decrease or removal of medications might make her feel better. I do, however, feel bad that she's having so much more increased anxiety from the change of decreasing the lorazepam, while I do notice that her MoCA score is improved. So her attention and her orientation seem to be better, but it hasn't significantly helped her functional status. I also wonder if the Aricept is also somehow to explain the improvement in the MoCA, but that's just a side question. So I also have stressed in the past to start looking for more assistance, because her housework, the clutter in her home, the clutter in her office especially, is what seems to give her a lot of overwhelm, and it's kind of a repetitive conversation we've had. So in my previous case presentation, that was the main, one of the main tips was to advise her to simplify her home and see if that could decrease distress. So she's not done that, but this time in the appointment, she admitted that she's not feeling confident about managing her finances, and her husband has basically said that he's not confident and able to manage their finances either. So they both expressed that they were very reluctant to ask for help, but they did say that their daughter, who lives locally, has a husband who's an accountant. So they said that maybe the daughter's husband could help them with financial, personal affairs. And And they did give me permission to contact the daughter, which I have not had any conversations with her yet. So I have no real sense of what the relationship is because of their they make it sound like they see their daughter somewhat frequently, maybe every few weeks, but she hasn't been involved in helping them with their household affairs up till this point that she hasn't. And I imagine she's somewhat aware of her mother's depression since it's been ongoing for decades at this point. But it sounds like they really haven't talked to their daughter about the patient's medical care. And then that last sentence just about her decreasing her propranolol. And I did notice on the MOCA that her tremor was significantly worsened. She didn't mention that it was impairing her ability to function as well, but I kind of wonder if improving her tremor would somehow help her functional status more too. Okay, move on. So my questions would be some advice on how to have a conversation with a daughter that would be the most effective ask for the daughter to start being more involved, especially not knowing the dynamics, to relay concerns about the depression is very significant. The cognition isn't helping, and that both her mother and her father, which I don't have the father as I don't have the spouse as a patient, so I don't know exactly his cognitive function. I usually have a better sense in talking to someone on their level of cognitive impairment, but I can't quite gauge from him because he jokes a lot. So I never quite understand if it's a cover for him having cognitive impairment too. He still drives. He seems to be repetitive in the same sense that the patient is repetitive. They say the same thing every time. So I don't know his level of cognition, but he's not significantly affected where I can tell. But he does self-admit that he doesn't do finances. He's never done the finances. So I think that is probably the way I'd state it if I were to talk to the daughter, that he just doesn't feel comfortable. Oh, I feel frustrated with goal 2, question 2. I feel frustrated with the ability to refer to psychiatric care, because I imagine there are psychiatric providers who could see her. There's a Lourdes counseling center that has the majority of psychiatry in the area, and they have counselors. And so I imagine she will be able to get into Lourdes, but I don't absolutely know. I know that there is a lack of psychiatric care in the area. So that gives me a lot of anxiety with this fear that that maybe even if she were to pursue the referral, that she might not even get into a provider. So that makes me nervous that then my follow-up plan will have to be to somehow find out what will make her feel better while reducing polypharmacy with her current medications. And then maybe insight on, I've had 2 patients, because of this lack of psychiatric care in the community, I've had 2 patients actually use telemedicine to establish care with a telemedicine psychiatric provider. And both of them have had amazing improvement with that service, because it's a specialty. It's something that I think really is, when you have a resistant depression or anxiety, it's better served to have managed under a psychiatrist. So I was wondering if there were any insights on how to. Now, both of those patients who had the telemedicine psychiatric care, they're paying out of pocket for that service. So that is a bit of an ask. For like this patient, I've asked her to consider hiring a caregiver. And I know that she has some financial means, but I don't know how much. And so I don't know how much if that comes to that case, I don't know how much I could press her to even consider an out-of-pocket psychiatric provider. And the third question is that she's been established with a neurologist in the past, and my goal would be that I see patients at the Catholic Senior Clinic Geriatric Care, and I've kind of posed it at our provider meetings at least once, that maybe we have more of a collaboration with our local neurologists, like a meet and greet or some sort of relationship, because I've as things how go, you can work very closely and have the same patients and never physically meet specialists. So I know of the neurologist she's gone to in the past, but I really don't know how I'd reach out to the neurologist or what I would ask about her case to help. She's on Aricept. She is, it seems, more of a psychiatric concern with the demotivation, but if there was something I could re-refer for or reach out to the neurologist about, I'd be curious of an insight on that.
Thank you, Julie. Thank you for the update and all the great work you are doing with her. I'm curious, from our community here, what questions do you have about this case before we launch into recommendations or ideas?
Hi there. Is it okay if I just pop in and speak? I'm a geriatric care manager with Aging Wisdom in Seattle, and we consult with families. And it was so interesting hearing you talk about this patient because it's eerily identical to a client that I've been working with for the past year. But I wanted to comment more about your question on how to have a conversation with her daughter. And I was just curious, do you happen to know if she's done her power of attorney paperwork? Has that come up at all?
Question. That's a great question. Let me look it up real quickly because we would have it documented. I feel like I have asked before, so I'll have it up in a moment.
Okay.
Because offhand, let's see, we do not have offhand. There was a conversation in the past, and similar to, they've had it done, but we've not received it, is what I have documented.
Yeah. Yeah, it's just something that, especially for longer term planning, seems like such an important piece because you're seeing the both of them. Not, a lot of times what happens is married couples appoint each other, but not necessarily an alternate, which becomes problematic when they can't be effective for each other.
That's perfect, because when I'm thinking about like what I have to talk about, prioritize with the daughter, maybe would be a priority to say, let's make sure that power of attorney does state you as a designee.
Right, provided that she's able and willing to do that, because it sounds like there's a question about the relationship. So I'm so glad you have permission to reach out to her, and I would almost suggest just like starting with questions to see what she can offer. Curious about your relationship with your parents. Have you noticed changes? Do you know anything about their estate planning to know who they'd rely on if they're not able to manage anymore? And I think that would be a nice lead into the conversation.
Yes, that's a good thing to start with questions. And I think that's the normal course, is I usually do a very soft open of, have you any concerns? Have you noticed any change? I'm seeing your mother for some cognitive concerns, and I'll say that I'm seeing her for depression, but I still feel like I'm not doing her any great service when it comes to depression. But it sounds like maybe previous providers had the same frustration of treating and not making any headway on at least the self-perception of how her depression is going. So I didn't put it as a question. Her previous internal medicine provider had put in maybe ECT as a treatment choice, but I mean, that is also not within my power to recommend or refer her for, I don't think. I think it would be a psychiatric provider. That's just a little aside.
Good questions. Yeah, and I'm curious too. I'm gonna suspect that Trang has got some ideas about medications. We're going to want to hear about that in a second. And I'm curious also to get Dr. Parsi's take on those MOCAs. I suspect there's something that jumps out about those. And then Dr. Demoto Riley's thoughts about the neurologist question. But I'm curious, are there other, either questions or maybe suggestions, since we've got about 13 minutes here, suggestions for Julie about how you might approach this, or recommendations? I like the idea of the intro conversation with the daughter about the POA and other advanced care planning documents.
I'll just add one more thing. Again, because this feels so similar to a client I'm working with, I liked your idea of seeing if there'd be an option for her to hire a caregiver or companion. Not sure what those resources are in your area, but that's something that's been really helpful with the client that I've been working with. She doesn't need any help with her ADLs. She's perfectly independent there, but we've had a companion seeing her twice a week just to put a little structure into her life and create some diversion. Help her initiate on things that she hasn't been able to do on her own, like you talking about streamlining the house. It sounds like she thinks that's a good idea, but can't really initiate on it. So I wonder if there's someone that could help with that. And then it also becomes someone else that has eyes and ears to know exactly how she's doing day to day and where she might need more support.
I like that suggestion. I like that term too, the kind of help initiate. It's great. Because I think you're right to say that she's not needing help with her ADLs. And so kind of having to sell the caregiver a little bit that this is also someone who can help her get things organized around the house and set things up for success for her.
And Julie, you might have mentioned this and I might have missed it, but you're pretty confident she is taking her medications as they are prescribed?
That's an interesting question because I get refill requests from her pretty regularly. So I think that she's taking her medications, but I don't know if she's taking them as prescribed. Her memory for her medications is appears to be good, but is there a way for me to know better? I don't know. I guess I could have her bring her medications in person, would be sometimes how I make sure she's taking all the medications prescribed and that all the medicine bottles have kind of recent fills and things.
Julie, this is Kimmy. I was just wondering, it sounds like it might be best, when do we think about having the daughter actually come to a visit? It sounded like maybe you were thinking it'd be best just to have a separate conversation with her. And then did you have a sense from the parents, basically, would they be comfortable with having their daughter come in to meet, all of them together with you?
That's a great idea. I mean, it's, I think that if the daughter was willing, I guess that's a great question for me to have from the daughter, is just if she's willing to be available, coming to the appointments too would be a wonderful thing. I think that's a great idea.
Or even offering, we can call you towards the end of the visit when we're wrapping up to just include her in any way. Yeah.
Right. So there's someone who can further follow up on referrals placed, recommendations done. So things, for instance, the other referral I've placed a couple times for her was physical therapy, which she said she wanted to do for her right knee and her gait. So I placed 2 referrals for physical therapy, which has just not been followed up on either time, even though she's the one who asked for it. And probably I encouraged it too. But it's like even the things that she wanted haven't been followed up on.
Kimmy, I'm going to put you on the spot. Do you have thoughts about the role of Aricept in the performance on that follow-up MOCA?
I do think of Aricept as sort of helping with sometimes sort of like an activating medication. So it looked to me, hopefully I was looking at it correctly, that she actually did better on the recall on the second one. Like she missed all 5 initially, and then, but with cues she got it, and then her, I mean, she was basically essentially almost within normal limits, because then she got all 5 that follow up. So I wonder if it's sort of giving her a little sort of attentional engagement boost. Yeah.
Good.
And we think about, is there a vascular component there? So, yeah. And well, Chris, I guess I can go ahead on the neurology movement riff then. I think it seems like she tried the propranolol. So again, like you said, that was one recommendation you made that she actually maybe kind of followed through with. So maybe circling back, I don't know if that neurologist could weigh in on other medications for movement. And then the other option would be, it sounds like physical therapy was tough for her to engage with, but occupational therapy, even just a one-time, her writing, I wonder if that's a frustration for her. I don't know in terms of her eating, but sometimes family can help look into those compensatory utensils, et cetera, but just sometimes even a one-time visit with OT in person can be so helpful. Is she buttoning stuff okay? All of that, it makes such a big difference to get yourself out of bed and enjoy your breakfast in the morning.
Yeah, I agree.
Other thoughts, recommendations, suggestions, things you might consider if this was your patient? Go for it, Tran.
Very complicated case, Julie. Not sure even where to start when I read this. I was hoping before this, her depression was under control, so we can start, cutting down dosage or cutting down medication or minimizing it. So I'm gonna go through what I think the problem is with medications, and then we can kind of prioritize which one to tackle. So propranolol, actually, any non-selective, non-cryoselective beta blocker can increase risk of depression.
Mm-hmm.
So I like the idea from Dr. Kimiko that maybe get another neurologist for another alternative for tremor. So was it because of the essential tremor that she's having, or maybe is it relating to the antipsychotic, the tremor caused by the antipsychotic that she's taking? So we're not sure.
Yeah, the essential tremor has been present for a long period of time, and the antipsychotic she's only been on an antipsychotic now for probably a year and a half. Yeah.
Oh, okay. So I like the idea of physical therapy and consider another alternative. So just keep in mind that beta blocker, especially the non-cardioselective, can cause depression or contribute to depression. The other one, because of her history of falls or anything that increase risk of drowsiness, can increase the falls. So benzo is up there, lorazepam. So I know that you cut it down from 3 times a day to twice a day, and anxiety seems to get worse. Instead of cutting down from one tablet or 0.5 milligrams 3 times a day to twice a day, maybe we keep it 3 times a day, but do half a dose.
Mm-hmm.
So she feels like she's still taking it 3 times a day, but then each time is only half a dose.
Ah, interesting. Yeah.
So maybe that's another approach. So that can increase can decrease the risk of falls, decrease the risk of dizziness. And then you mentioned you increase mirtazapine. Is her depression is not better after the increased dose of the mirtazapine?
She has only been on the 15 milligrams so she's not had any dose changes. When we first started the mirtazapine, it looked very promising. We started it. Let me look at the history. We started it, and then the October visit was a follow-up on the mirtazapine, and at that time she was feeling better on the mirtazapine. That's the hard thing with her self-report and the PHQ-9 and the GAD-7. It's just the numbers it's hard to gauge whether they're really truly reflecting what she's experiencing, because her self-report sounds to be stable, or even she's not mentioning crying at this last appointment, whereas in the past she says that she'd been crying all the time. So she might be her numbers might look worse, but she's not crying all the time, and she's still just as demotivated, but she is reporting more anxiety. So I was hopeful that the long story, the mirtazapine has only been at 15 milligrams, and she initially seemed to respond well to it.
Okay, I just noticed that she sleeps 10 hours a day. So, so that's something that if it's not helping, if mirtazapine is not helping at increased dose, and she sleeps a lot, so maybe she does not need to be on that dose. But that's something to think about, so to reevaluate. The other one is citalopram. What is the latest EKG?
So we've not done one for 2009. We don't have an EKG, no.
Okay.
2019.
Okay. She is on 40 milligrams a day, which is for seniors a high doses because of increased risk of QT prolongation. And then also combining with the bupropion can increase the drug level of citalopram. So that can also, she's on a high dose, and bupropion can increase the drug level. That can also increase risk of the QT prolongation. And I look into the drug interaction. Actually, escitalopram does not have that drug interaction with bupropion. That is something that you can consider later. We change one medication at a time, but that might be something to consider later, to switch to escitalopram to avoid that drug interaction. There's still some drug interaction because of the drowsiness, but there's no drug interaction in terms of increasing the drug level of the SSRI from the bupropion.
Okay.
And then, yeah, I would recommend doing EKG to see where she's at.
Great.
And then the lamotrigine. So lamotrigine is actually used only for major depression in bipolar. Do you know if she has history of bipolar?
Yeah, the only history I have about the lamotrigine is that when she established with me, she told me just longstanding depression started after her children moved out, kind of like that loss of a homemaker mother role, and that she was told just never to be off that medication, which sounds like at some point maybe someone thought she had bipolar, but there's no history of mania or cycling or that I've been told.
So lamotrigine actually can cause a very, very life-threatening skin reaction. And that's why it's usually taken at a lower dose and then go up. And then maybe she might have misunderstood that if someone who missed a dose of lamotrigine, let's say the medication is tapered up to a higher usual dose, and if they forget to take it for a few days, when we restart, we have to restart at a lower dose to avoid that life-threatening skin reaction, including Stevens syndrome. So I talked to a psychiatrist at a clinic. Anytime the patient misses more than 2 days of lamotrigine, they want to be notified because they have to start the patient at a lower dose. So maybe the patient might have misunderstood that she never missed the dose. So it doesn't mean that she cannot get off of it.
Right.
It means that she can miss it. So,
no, that is a good, because I always am frustrated when I hear a patient say like, oh, I have been told never to take this, or I've been told never to come off that. And it's just a blanket statement. Especially since she established, I questioned, well, why trileptal, why lamictagine? And I'm not familiar. I would like to have her on less medications. So there was that blanket statement.
Yeah. So that can be reduced as well. It doesn't mean that the patient cannot be reduced or even get off of it. It's just that when we know that when the patient missed the medication and let's say she's on 250 milligrams, and let's say she missed it, and when we have to restart, we have to start at 5 milligrams back up.
Well, even the question of like whether she's taken her medications regularly as prescribed, it would be if the daughter is more involved, it would be a interesting thing to see what the daughter reports in terms of how is medication set up. Are there, times when medications aren't taken, or just confirm.
Yeah. So
And
those
also-
are the,
Oh, go ahead.
oh yeah, so those are the medication problems that I identify. But now we just need to kind of tackle which one we want to prioritize.
Yeah,
That's
we
why
have
I want a
lot
really
of-
amazing psychiatrist to come in and just help.
Yes.
Absolutely. Well, and to Nicole's point too, the caregiver can be a set of eyes around medication compliance. That's another nice kind of a point of data. I am aware that there's a lot more to talk about with this case, and we're at 1:32, and I want to be respectful of time. So I'm going to invite anybody, whether it's any of you who have ideas or thoughts, feel free to email me or Allison any suggestions. But I want to make sure we're sticking to your schedules today. And I want to thank you, Julie, for bringing this case back around. Maybe we'll get a third, glimpse at some point, but much appreciated, and really appreciate the really amazing care that you're taking care of, or you're providing for this challenging case. So she's lucky to have you.
Thank you.
All right, with that, I think we will, I'm not going to share my screen, but I will let you know that our next session will be on pharmacological management of dementia. And Allison, you'll have to remind me if we have a case already, or I'm just going to ask for a case anyway.
We do have a case. I believe that Trang will be delivering a case that day.
Oh, that's right. Outstanding. That's outstanding. Okay, great. Well, then we will look forward to seeing you then, and we'll trust that you'll have an excellent day, weekend, and time a bit from here on out. All right. Thanks, everyone.